Good afternoon, everyone, and welcome to the Board of Pharmacy webinar today. I'm Tom Glinsky, Chief Inspector with the board. Our topic today is a HealthNet Pharmacy Program update. Today with me, we have Olivia Rush. She's a Program Integrity Pharmacist at HealthNet, and then Joshua Moore, the Director of Pharmacy at HealthNet. So welcome to you both today, and thanks for coming. Before I turn it over to them or go through just some introductory slides, if you haven't been on our webinars before, you're muted. If you have any trouble with audio via the computer, on your GoToWebinar toolbar is an option that you can change to use a telephone, and it'll give you dial-in and code instructions on how to join. This has been approved for 1 hour of CE. You must be logged on to GoToWebinar under your own username in order to get CE. I have more instructions at the end of the program today. Just a reminder, the board does not submit CE to the CP monitor, so make sure you save your certificates. And I just want to caution you, if you're licensed in other states, don't assume that that state will accept a CE from us. It's not ACP approved, and I have had a pharmacist tell me they did run into some trouble in another state. So don't assume that. Make sure you check with them if they'll take a CE certificate of something approved by another board. If you want handouts for today's webinar, you can get them in two places. You can go to the board's website, and on the left side under upcoming events, you click that and there'll be a link there to the handouts. Or you can go to your GoToWebinar toolbar down at the bottom. If you click the tab handouts, you'll see a PDF there of the handouts today. We do record all our webinars, and you can find them on the board's website. And we hope to have time at the end to take some questions from our participants. If you'd like to send us a question during the webinar, go to your toolbar, type it in, and hit send. We will only answer questions related to today's topic, so we'll keep it on track there. And then at the end, I'll show you again how to send questions. So I'm now going to turn it over to Olivia.
Thanks so much, Tom. Hi, everybody. Good afternoon. Like Tom said, my name is Olivia Rush. I'm the Program Integrity Pharmacist with HealthNet, and I also have with me here today Josh Moore, our Director of Pharmacy. He'll be here to throw in his tidbits and help us answer questions at the end. So while everybody peruses over the agenda, I did just want to let everybody know that throughout the presentation, I have included some hyperlinks for certain references and different topics. Those are going to be highlighted in green, so that's not a formatting error. I promise that was on purpose. So to start off today, we just wanted to do a brief overview of what our enrollment and spend looks like. Over the past few years, we've actually had quite a bit of uptick in our monthly enrollment, and this is due to a couple of factors, one being the continuous coverage rules during the pandemic, and number two being the expansion of Medicaid here in Missouri. So you can see back in 2021, we had an average monthly enrollment of roughly 1 million lives, and now today in 2023, we're sitting closer to 1.4 million lives. It really is encouraging to see this increase in enrollment and to see more people gain access to healthcare. However, with the unwinding of the PHE, we are very likely to see these enrollment numbers change. And it does make sense that with an increase in enrollment that we do see an increase in spend. So for fiscal year to date, we're sitting at roughly $1.99 billion, when back in 2021, we were sitting closer to $1.56 billion. And this is truly only for the pharmacy program spend, and this is not HealthNet as a whole. And it probably comes as no surprise to anybody that with this increase in enrollment that we have also seen an increase in our prior authorization request. So we are wanting to hit here today and ensure that everyone knows that PA requests must originate from the prescriber's office or the pharmacy with the established patient relationship. Unfortunately, we've seen an uptick in the use of third-party prior authorization vendors such as CoverMyMeds or ZapRx. They try to promise an easier PA process through automation. However, a lot of times this causes undue barriers, which can lead to extra delays and complications in the whole process. So we wanted just to hit some of the highlights of the barriers that we do see. One being the use of a generic prior authorization form. These third-party companies just have a standard form that they use to create their PA forms and send to HealthNet. However, HealthNet has very specific prior authorization forms for certain sets of drug classes, one being our hepatitis C class of medication. Josh just told me just the other day of a story where we saw a prior authorization come from Cover My Meds, and it was using one of the generic forms, and it had included an additional 20 to 30 pages worth of documentation that was unnecessary and unneeded. Well, one, we didn't accept it because it came from Cover My Meds, but two, we have a simple one-page hepatitis C medication prior auth that you can very easily use and access on our website. Any kind of other documentation to additional documentation, like I mentioned, the 20 to 30 pages, any additional documentation or just information is not accepted by these third party, or is not accepted by HealthNet from these third parties. And we as HealthNet do not share any additional patient information or claims information with these vendors. A lot of other things that we see whenever these come across are missing information in general. The patient's name will just be blank, so that's not helpful to anybody, or the information received is not accurate or relevant. We've seen multiple times where the prescriber's name is placed in the participants field. Again, very confusing to our help desk staff and is not helpful when trying to review these PA requests. Here's just another example you can see on line 2 where it says requested drug name. It simply just says compound drug. That's not beneficial in trying to review this PA. The prescriber is not going to get the response that's needed because we will not respond to the provider directly saying we need more information. And again, this just creates extra delays and complications that's unneeded throughout the whole entire prior authorization process. During my time here with HealthNet, a lot of the times we can get some complaints about the lengthy times, and a lot of that just really originates and is driven by the use of these third-party prior authorization vendors. Our next topic that we wanted to bring today is an initiative that we have partnered with the Missouri Board of Pharmacy RX Cares for Missouri program, along with the Department of Health and Senior Services, and it's our Safe at Home Patient Safety Opioid Initiative. The overarching goal of this initiative is to help promote medication safety, to prevent prescription drug abuse, misuse, and diversion. And one of the main ways that we have done this is HealthNet has opened access to what are DisposeRx packets. They are our preferred at-home oral medication disposal packet. They're a really cool product. You can get all kinds of information on their website. It's disposerx.com. It's got a ton of patient handouts and educational materials for them. But how the packets work is the participant will pick them up from your pharmacy. They will then take them home and add a little bit of water to their prescription vial. So any kind of unused medication or expired medication, they'll add the contents of the packet to that vial with the water, put the lid on, give it a shake for roughly 30 seconds, and then they can safely dispose of that medication within their trash at home. So super easy and convenient for the patients to get rid of all that extra unnecessary medication. Well, HealthNet will reimburse these pharmacy providers who dispense DisposeRx packets to eligible HealthNet participants at risk of experiencing an opioid-related overdose. And we also have had to implement a limit on these packets. It's 2 packets per participant every 45 days. My job as the program integrity pharmacist is to help watch outliers within our claims data, and we have unfortunately seen a little bit of misuse with this product. We've seen what appears to be pharmacies dispensing these with every single prescription that goes across their counter. We've also seen some prescriptions being for 30 packets for one patient. Again, we really want to make sure that the patients that you are giving these packets to are within the appropriate eligibility group. One easy way for you guys to be able to dispense these to your participants is to utilize the DHSS statewide standing order. This was renewed early May by Dr. Heidi Miller. I'm sure you guys all saw these with Dr. T, but it's now Dr. Miller on that standing order. The standing order allows for no refills. However, in our claims data, we have seen many claims come across with additional refill, so please ensure the accuracy of your claims there. And another note for the no refills, when your patient does have a need for additional packets, do not generate a refill request and send it to Dr. Miller's office if the original prescription was obtained via the statewide standing order. It just causes an undue burden to her staff and even your staff, as well as you're trying to then wait for Dr. Miller's response, and they're just going to come back and say they don't have an established patient relationship and that the prescription originated from the standing order. Also within the standing order, they have their own criteria for eligible patients, and there is a requirement for patient education that I'm not sure that everyone is aware of. So please, again, click the highlighted green hyperlink and you can take a look at that yourselves. Another clinical edit that we have recently, well, I say recently implemented, it's been out for quite a bit now to help with the opioid crisis, is our high-risk therapies clinical edit. What is high-risk therapy? So HealthNet believes that to be an opioid plus a CNS depressant, so benzodiazepine, sedative hypnotic, gabapentinoids, and as healthcare professionals, we all know that this combination can cause sedation, impair cognitive function, respiratory depression, and could even potentially lead to a fatal overdose. Even though we are aware of those warnings, we are still seeing this combination or combinations of these used quite frequently. And so for HealthNet, if a participant does have history of an opioid plus one of the CNS depressants that I mentioned above, we require them to have a documented history of at least one claim for an opioid reversal agent in the past 2 years. And I want to say that again, one claim for an opioid reversal agent in the past 2 years. We have seen some confusion with this edit where pharmacies believe that the Narcan or naloxone has to be given with every single dispensing of the combination, but that's not true. It's just for one claim every 2 years. And we get a lot of questions too of where did the past 2 years come from? And the past 2 years is really due to the shelf life of Narcan. It can be safely used for up to 2 years. One thing that we have heard from pharmacies is they don't want to call the prescriber who is prescribing the opioid and the CNS depressant together to get a prescription for Narcan or naloxone, but thankfully in late January, Dr. Miller again renewed a statewide standing order for this product, and this one does allow for multiple refills, but again, if your prescription originated via the statewide standing order, please do not send or try your best not to send those refill requests to Dr. Miller if there is a need for additional fills. One other thing that the statewide standing order also requires is that patient education piece, and a lot of times we hear back from pharmacies saying that our participants do not want to pick up the prescription for the Narcan, but we believe that if you take the time at pickup to properly educate on the benefits of the Narcan and teach the patient how to appropriately use the medication, they'll become more comfortable and more willing with the medication. And with this kind of right approach and adequate education, we believe that no patient should ever want to refuse to have this at their home to help prevent an accidental overdose. Another one of our initiatives that we've recently implemented is our short-acting beta agonist inhalers and nebulizer solution limits. Our main driver behind this one was to help prescribers be aware of the overutilization of SABAs and to promote SMART and other maintenance medications therapy to reduce exacerbations. We actually, back in 2021, had quite an alarming statistic where greater than 40% of our participants were using 3 or more SABA inhalers per year. And as you can see that I have listed on the screen, that kind of utilization is associated with an increased risk of severe exacerbations. We also saw in 2021 that greater than 6% of our participants were using 12 or more SABA inhalers per year. And again, on the screen, that's associated with an increased risk of death. So truly, these limits were to help promote safety for our patients, reducing those exacerbations and making sure patients' asthma is more controlled. So I've listed here on the slide our limits. So we allow for 3 inhalers every 6 months for only the adult population. So we currently do not have that limit on the pediatric patients, but there are limits for both adults and pediatrics on the vials, and we allow 120 of those every 2 months. Since the inception of these limits, we have found that the lack of compliance has really driven this need for additional albuterol. And we've also seen that patients were unaware that there are other additional medications that they can use, like controller medications, to help control their asthma. We were unsure if everybody was familiar with SMART, so we thought we would do a quick overview of this. And so SMART stands for Single Maintenance and Reliever Therapy. This is a SABA-only alternative to the treatment of asthma. It utilizes the combination of inhaled corticosteroids and formoterol. The ICS component helps with the anti-inflammatory treatment portion, and formoterol actually works as quickly as albuterol, but the duration of action is much longer. Here at HealthNet, we actually cover some products that fall underneath this SMART therapy. That's Symbicort and certain strengths of Dulera, and we don't require any kind of prior authorization for those medications. We also do not have a prior authorization on our spacers or peak flow meters if participants have a need for those. And through the GINA guidelines, or the Global Initiative for Asthma, it's been shown that SMART therapy will help reduce the risk of severe asthma exacerbations compared to SABA-only asthma treatment. And with this being a Board of Pharmacy update, we also just wanted to give a quick tidbit too of how you should be billing SMART. Whenever you receive a prescription for SMART therapy, most generally it will have PRN usage in the SIG, and so HealthNet will approve claims when they are billed for 2 inhalers for a 30-day supply. I just want to guide your attention to the second reference that I have on the slide. It's titled MHD Albuterol Limits Clinical Update for Pharmacists. This is a very cool handout that our clinical nurse created, and it's a helpful guide on teaching your patients how to utilize SMART, and then also more information on how to bill it appropriately. Next up on the list of things to talk about is the expansion of our pharmacist provider services that took place in early April. We now allow pharmacist providers to receive reimbursement for services that fall within their scope of practice that's defined by the Missouri Board of Pharmacy. These services must fall beyond the scope of dispensing medications to participants in those kind of day-to-day activities. Whenever you are wanting to utilize or render one of these services to our participants, I've created a short checklist here of what we ask the pharmacist provider to complete. So number 1 making sure that you verify the eligibility of the HealthNet participant prior to performing any service. This can easily be done via EmoMed. Making sure that you document that service within the participant's medical record. This is key, as this documentation will legally verify the care that was provided. And this documentation really needs to be complete, legible, and concise. You can reference the medical services fee schedule to take a look at all of the covered CPT codes and their relative reimbursement rates prior to completing a service. And then once you've completed the service and you are ready to submit a medical claim, that can be done through your medical system or through EmoMed, and we ask that the pharmacist provider be listed as the performing provider. We are constantly reminded that there are individuals who want to enroll as a HealthNet provider or a HealthNet pharmacist provider. Pharmacists can bill for different services such as COVID-19 tests and nicotine replacement therapy here in Missouri. Even though we have opened up the ability for pharmacists to enroll, we haven't quite seen the uptick that we had hoped to see. You can see back in 2020, our number of enrollments was around 178 compared to our current year to date of 234 enrollments. So that number has gone up quite a bit, but I really want you to take a look at the number of pharmacists that have billed for services. In 2020, there was only 27 of them, and as of this year, 73. Our provider enrollment is taken care of by Missouri Medicaid Audit and Compliance, or MMAC, and they've put together a really great debrief over how you can enroll and the different options of enrolling as a pharmacist. And so I've included that link on the slides as well. Now, it wouldn't be a presentation given by a program integrity pharmacist unless I actually spoke on something related to program integrity. So I'm going to hit some highlights on our white and brown bagging issues that we've been seeing. For those of you that don't know, white bagging is when a pharmacy will ship a participant-specific medication to a physician's office, hospital, or clinic for administration. A lot of times these medications are specialty, and so they come from specialty pharmacies. And once the provider receives that product, they'll hold the product until the patient arrives for treatment. Brown bagging is very similar to white bagging, where the specialty pharmacy will dispense, or a regular pharmacy will dispense the medication, but instead of shipping it to the physician's office, the participant actually picks up this prescription at the pharmacy and then takes the medication, as in an actual metaphorical brown lunch bag, to the physician's office for administration. So some examples are the Depo-Provera long-acting antipsychotics. And since we just got done discussing the pharmacist provider services, we just wanted to let everybody know that the administration of these kinds of medications, so your Depos and your long-acting or your LAIs, that can be done by a pharmacist and billed under the PPS services. So I said it was program integrity related, and so I'm going to walk through some examples of what we've seen in the past. So for this example one, the participant's medication is dispensed by the pharmacy, shipped to the physician's office, and is being held for administration. However, the physician's office never actually administers the medication to the participant, and this could be due to a multitude of factors. So then that requires the medication to be destroyed. As we all know, once a medication leaves a pharmacy, it cannot be sent back to the pharmacy, or the pharmacy cannot accept that. And utilization of participant-specific medication for another participant is prohibited. So in this kind of scenario, the pharmacy is responsible for that cost if the participant never receives the medication. So we actually saw this in practice happening just last year during the RSV season with Synagist, where the pharmacies were filling the medication, they were sending it to the hospital, but the patients never came to their appointments to have it administered. The hospital called and asked if they could administer the medication to a different patient, which we told them no, that is prohibited. and then the claim became fully recoverable because the patient that it was intended for never received the medication. So in the specific example, the pharmacy ended up working hand in hand with the clinic and the hospital to ensure that patients were truly going to be able to make it to their appointments, to ensure that there was never any abandoned medication. In this second example, we have two providers who are billing for the dispensing of a medication when only one provider should be billing for the administration. So I'm just going to jump straight down into the orange chart. You can see that Pharmacy A dispensed medication A on January 22nd. And then about a week later, we see a claim from Hospital A, still drug A, dispensed on 1/28. After we called and talked to both providers, Pharmacy A really dispensed the medication, billed us $13,000. Hospital A only administered the medication on the 28th when the patient came in for their appointment. However, they also billed us for $13,000. This resulted in a duplicate bill, and it also looks like our utilization is higher for this particular participant. So again, in this instance, the claim from Hospital A is fully recoverable as they did not actually supply the medication, they only administered it. In the second example, you see that Pharmacy B dispensed the medication 10/9, Hospital B also had a claim on 10/10. However, for Hospital B in this example, you can see they only charged us a penny, and we actually see quite a few of these penny claims. It's an inappropriate billing is what happens in this example. So we're just trying to remind everyone to bill for the CPT code and the associated drug HCPCS code and NDC in those kinds of circumstances. As again, anytime there is an additional charge like this, part of my job is to go through and review all these claims, and all of these will be fully recoverable, and that could take an impact on your budget. This is just a reminder slide of a regulation, just again, a reminder, administrative action or sanctions could be opposed against a provider, so any kind of provider, pharmacist, pharmacy, physician, for failure to take reasonable measures to review claims for accuracy. And so this includes all types of billing errors, quantities, day supplies, your usual and customary charges. So it really truly is up to the provider to ensure the integrity of your claims and to ensure you are sending us the appropriate information whenever you bill for our participants. One of our last big topics that we're going to talk about is the participation changes within the Medicaid drug rebate program. A lot of times we do not cover these, or we don't present or discuss these kinds of changes, but effective July 1, there's going to be a bigger change that we believe will have a huge impact on quite a few pharmacies. So MDRP will no longer include the following manufacturers, and I've listed 4 here on the screen, and I'm sure everyone's eye is drawn to the first bullet point of Lupin Pharmaceuticals. This is a generic that is utilized by many pharmacies in HealthNet claims processing. However, if a participant is not, or excuse me, if a manufacturer is not participating in the MDRP program, HealthNet can no longer pay claims from these manufacturers. And with that, we cannot provide overrides for these manufacturers while they are excluded from the MDRP. So it's very crucial that you're aware of this upcoming change and start preparing now, so that way you can order in different manufacturings that's needed for the appropriate claims processing for HealthNet participants. We did put out a provider hot tip, I believe within the last week or so, that actually has more information on the specific labeler codes of these manufacturers. Labeler codes are the first 5 digits of an NDC. So I've only listed 4 manufacturers, but this change really impacts a total of 10 labeler codes. So be sure to click on that provider hot tip and ensure, like you said, you're taking all of the appropriate steps. Next, I just have a information slide. It's all about just different links and additional references that I use daily, and I think that others within the practice of pharmacy would truly benefit from using when you're trying to bill HealthNet claims. So we actually met with a few providers, a few pharmacies, excuse me, and together we built a pharmacy provider resource guide that walks you through all sorts of things, eligibility, TPL, etc. So please check out that if you have questions or concerns. The next one is the Pharmacy and Clinical Services homepage. This will take you to the main page where you can find the rest of the links, or you can navigate through the website to get to the below links. Our frequently updated documents link contains information about new drugs that come out, when they'll be reviewed at our different advisory meetings. It has MAC pricing lists. It's got over-the-counter list, covered vitamins, things along those lines. So those are very helpful whenever you're trying to process claims. The clinical edit and PDL documents, super helpful. They contain all of our criteria for the specific PDL documents and agents that we have clinical edits on. There's a link here to the calendar of events. This one takes you to the whole calendar for the Department of Social Services as a whole, and you can see when we're having different types of public meetings that we welcome you guys to join. And speaking of public meetings, the next bullet point is our advisory group home. We actually have 3 different advisory groups that we meet with every single quarter. So we meet January, April, July, and October. We have a rare disease advisory committee, a drug prior authorization committee, and a drug utilization review board that we meet with and review all of our proposed criteria for our edits that we have. This is a public meeting. We really do encourage all providers and pharmacies to enjoy. Oh, and a new change with the meetings for rare disease, DPAC, and DUR. We now offer professional continuing education through the Board of Pharmacy, and each one of those is roughly between 3 to 5 hours, so you can knock out quite a bit of CE if you come and join those as well. And then the last link there is just our PDL searchable database, and hopefully if time allows, I'll be able to do a quick demo of that so you guys can see all the cool functionality and what all it entails. We all know that staying up to date is super important, and I've mentioned quite a bit that we have hot tips and provider bulletins. This link is how you can sign up for those. You just hit that link and a pop-up box that's highlighted there on the left will come up, and you can easily just add in your email address and subscribe. We promise this is not full of a whole bunch of spam information. It really is important information. We send out different criteria changes weekly, and it's just full of great information. And we highly recommend everybody sign up to get those alerts. It's come to our attention that almost everybody knows the second phone number that's listed on the screen, our HealthNet prior auth help desk phone number, the 800 number. We know it by heart. We know and love the whole music that they have, but someone that you don't know and you might utilize quite a bit is our pharmacy administration unit. They actually sit right outside my office. They can answer any kind of HealthNet billing questions or issues that are unrelated to prior authorizations. You'd be surprised by how many pharmacies do not utilize these guys as a resource. So I've included their email address, their phone number, and even their fax number as well. And I believe this is my last slide, and we just wanted to run over some things that are up and coming that we wanted everyone to be aware of. So effective July 30th of this year, HealthNet is implementing an automatic refill program regulation. However, we wanted to use this as an education point. We did receive additional comments after the comment period was over. So almost as soon as this one goes live, this will be amended and there will be changes made to that regulation. So it's super important that if you do have comments that you please submit those during the comment period so we can address them prior to anything being posted and going out. In September of this year, be expecting a HealthNet manual redesign. This includes pharmacy, physician, the general section, hospital, so on and so forth. It's getting a complete overhaul, and that will be available soon. And I actually have a typo on this slide. It's November 30th of this year. So we're doing a HealthNet pharmacy website redesign. So I know I just gave you links to a ton of great information and a ton of those great links. However, those will change. But it's going to be so much easier to navigate and to use, and everything will just be available at a click of your fingertips come November 30th. And so I think that we have time.
Did you want to do your demo?
Oh, I did. If you wanted to go ahead and do that.
Yeah, let's go ahead and do the PDL Central database. And then we know that right now the links, you aren't able to click on them because it is PDF, but we will work with the board and see if
Yeah, I'm not sure what happened there. Normally you can when we, so I will try to PDF it again and see if we can correct that and send it out.
So I clicked on the pharmacy home screen so everyone can see the pharmacy and clinical home screen whenever you get there. And I just want to kind of walk through different steps. So again, here you can find the advisory group meeting information, our calendar events you can find over here in the corner, but I'm going to click on pharmacy. And then again, you'll see a calendar of events, our frequently updated documents that I kind of talked about, clinical edits and PDL documents, which I'm going to click through to get to the searchable database. And again, here's all of our criteria you can find. They're hopefully very easily laid out. I'm going to click here on the searchable database. And so you can see here, you can search by NDC, brand name, generic name, any of our drug classes. If you're looking for a specific date, like a retrospective date, to see what the coverage was or the status was, you can change the date here as well. It only requires the first 3 letters of a drug. So here I just typed in amoxicillin, and you can see that we have quite a few entries, especially if I scroll down here, you can see there's 1 to 194. I can click over here and navigate through the different pages. And also if I scroll back up, I can actually change how many entries I can see at a time if I wanted to take a look at more at once. The really cool thing about this is that it's NDC driven as well, so you can see the specific NDCs and tell whether or not they are non-preferred or preferred, even what drug class they fall into. You can also search within these results. So if I was searching for the 500 milligram, oh my, numlock, 500 milligram capsule, I just typed in 500, and anywhere that the searchable database sees 500, that'll populate. So it can help narrow down your search a little bit. And then again, you can see what's preferred, non-preferred, the specific NDCs that we cover. And again, just at the bottom, it only now pulls 1 out of 100 or 1 out of 33 entries instead of the full 194. If you're also wanting to see what other things we cover within this drug class, you can click on the drug class and it will pull up all of the medications and not just what you searched for. So hopefully that was helpful. You can also sort by any of the titles, so drug name, strength, NDC, drug class, whether it's RX or OTC, and even the PDL status if you're trying to do a quick search.
Yeah, so one note on the PDL searchable database, that's only going to contain products that are actually on our preferred drug list. We don't have every single drug on our preferred drug list. So there are some products that don't have any clinical coverage requirements or preferred drug list, but we have a preferred or non-preferred product in the class. Those are not currently available on the PDL searchable database. We are currently going over and looking at our options to potentially include all covered products. But I can tell you it is a very complex set of requirements to create the list and manage and keep it up to date to the day on what drugs are covered on a given date of service.
Okay, we're going to now take questions. If you'd like to send a question in, go to your toolbar and you can type it in and hit send. Before I turn it over, there was one question that came in for me asking what state was I talking about that had issues with the board CE. I believe it was Kentucky. I don't know the outcome of that. I just know they did question the pharmacist about our CE, but I don't know the outcome if it got accepted or not. So I'll now turn it over to Olivia and Josh to take some of the questions that came in ahead of time. And then we did have some coming ahead, and then we have some coming in during the program today.
Okay, so one of the first questions that came in earlier prior to the presentation was asking why the help desk doesn't give out specific NDC numbers that are covered. So HealthNet does not have a preference when it comes to certain manufacturers. Again, we went over through the participation of the MDRP, and that also plays a huge role in us giving out NDC numbers. We just went through the PDL searchable database, so hopefully that is an additional resource that you can look to see what's covered and not covered. And also, I mentioned the pharmacy administration unit. Those guys are there to also help you if you get stuck in these kinds of situations. So again, please sure to utilize that resource. Another question that we received is, will HealthNet cover oral COVID-19 antivirals? And we do cover those without any kind of restriction. We do know that Paxlovid is still has limited distribution, and HealthNet has no control over that. But overall, if a pharmacy can get the medication, we will reimburse for it.
All right, and then we also received the question, why does Medicaid only cover brand name for some products when generics are available? And the reason is, when we evaluate the cost to the program, we evaluate based on the net cost, the final net cost of the product. So we have to take into consideration both the reimbursed amount and the rebate we receive back from the manufacturer through the Medicaid drug rebate program and through any supplemental rebates that we have negotiated. So much like when you go to the grocery store, if you see brand name cereal on the shelf for $6 and the generic cereal is $3, if you have a $5 coupon, I think we would all pick the brand name cereal and save a couple of dollars that way. When we talk about the size of the Medicaid program, a couple of dollars here and there adds up significantly to the point that we are now collecting right around $1 billion in rebates back from the manufacturers, and that goes directly to funding the program going forward. A couple of other questions that we've received since we started the chat. Will Medicaid cover expensive weight loss products and early Alzheimer's drugs? At this point in time, HealthNet does not cover anti-obesity medications, and we do cover Alzheimer's medications, though. We are allowed through the federal program to exclude certain classes of medicine, and anti-obesity medications have been one of those classes to date. Alzheimer's medications are not one of those classes. We do cover those products. However, we have not yet received any requests for coverage. I was asked as well about printing off the interventions within Cyber Access so that can be completed offline, and then the pharmacist or technician could go into Cyber Access and complete based on the information provided. And you have that capability already. If you are having difficulties printing off those materials, please reach out to your provider outreach representative, and they can help you out on how to perform printing. Okay. On the autofill regulation, the autofill regulation is actually posted out on our website. It is also in the register. So we recommend that you go out to the register and review the official document. It has been posted. If you have any questions on how to do that, please reach out and we will be more than happy to provide you a direct link. All right, is the Medicaid rebate criteria changing? And this is the reason my Lupin, Harris, CDMA, OTC, et cetera, are no longer being covered. And if so, will there be other generic manufacturers not willing to participate in Mo Medicaid? So there are a couple of different programs that we talked about. The MDRP that we've referenced several times is the National Drug Rebate Program. In order to be able to be covered by any Medicaid program in the country, the manufacturers have to sign the agreement with the feds, and then all state Medicaid programs would cover those products in one form or another. So these are companies that have either been kicked out of the National Rebate Program because they did not follow all the rules and procedures, or have opted on their own to not be in the program any longer and not allow Medicaid patients to have access to their medication. This is not a choice that Mo HealthNet is making. This is one that is being done on a national level. We got a couple questions about reimbursement based on those manufacturers being kicked out of the program. So reimbursement for most of the products that we're talking about are based on NADAC pricing, which is a weekly update. So if there is a difference in national average drug acquisition costs for those products, then that will be adjusted at a federal level. And then we would have that update within about a week and would be able to process with the new reimbursement rate if there was one, or if there is one.
Someone asked if we could put the slide up with the phone numbers for the administration unit, so I'll put that back on there for you. We have a question about DC Pro. If you need a collaborative practice agreement in order to do Direct Care Pro interventions, you do not. That's part of the point of being a provider. So we would encourage you to look over again the rules around Direct Care Pro, which we have spelled out in the provider manual. And then if you have additional questions, please feel free to reach out. We're just going through some questions too. A lot of these are actually duplicate questions. What CGM monitors are covered and under what criteria? Olivia went over really well all of our various links so that you can look at that information and stay up to date. As of today, we do cover the Dexcom CGM, and the criteria is that they need to be on a short-acting insulin within the last 45 days, 90 days. Mm-hmm. So we will automatically approve at the point of sale a Dexcom meter, transmitter, and sensor without any PA needed for someone that has received something along the lines of Humalog in the last 90 days. Next week, we will be updating that criteria for any type of insulin in the last 90 days. Turnaround time for a prior authorization, if all the information is provided to the help desk and the help desk is able to work through the flow chart, we can turn those around in less than 24 hours. Likely a number of pharmacies on the phone have experienced the approvals while we're actually on the phone with you in the real-time prior authorization. So I recommend making sure that when we ask questions that you answer those fully. We time and time again get 80 to 90 pages of documentation that do not answer the 2 or 3 questions that we are asking. MAC and NADAC prices are all publicly available. Again, if you look at the links that we provided, the MAC rates are listed there. The NADAC rates are actually posted on the national drug pricing website for CMS, and again, are updated weekly. There's a question about flu shots, and that's actually an interesting intersection between federal programs trying to do the right thing and Medicaid programs at the state level.
Medicaid is actually not allowed to pay for vaccine ingredient that is available through the VFC program. So that is why we do not cover flu shots in the pharmacy for kids for non-VFC providers. If you have questions about VFC, we recommend you reach out to the Department of Health. They manage the VFC program. There's a question in here about what services a HealthNet pharmacist could provide as a consultant who's not tied to a dispensing pharmacy or a physician. I don't know how you would find patients, but that is not a requirement necessarily for us to reimburse you. I can't tell you how to operate a business like that, but I don't think that would preclude you from us paying you for certain services. There's a question about a generic prior authorization form on the website for all patients. There is a more generic form on there, but there are certain products where we do have specific prior authorization criteria forms to help both the provider and us perform these reviews in a very quick manner. What comes to mind as one of our more complicated policies is the targeted immune modulators for allergies and asthma. That is a very difficult policy for a lot of people, and we need very specific criteria, so we ask very specific questions to process them as quickly as possible. We have a question here about the difference in pharmacist provider services. They currently bill through Cyber Access. Are there other services billed through EmoMed? We actually put out a very thorough bulletin explaining the difference. So I would recommend you go to our website and look through our bulletins and read the one covering pharmacist provider services. It details out what services are available and how you can search for additional CPT codes that may be covered. We've had a number of emails come into our help desk asking what CPT code should be used for various services, or if a service would be covered but not providing a CPT code. We are not providing codes in that manner, much like we do not provide NDCs. We would look at a CPT code perhaps if you send it to us, and we could tell you whether or not we would cover it. But again, I recommend you going out to our website, and you can actually see on our fee schedule what CPT codes are covered and what price it would be reimbursed at. We got a question for a name and date of the bulletin on our website for the pharmacist provider services. We're more than happy to share that with Tom, and we can share that as a follow-up item, but it is in our bulletins. And if you're signed up for our bulletins, you will receive those in your email.
And just as a note too on those, if you just were to do a quick Google search of HealthNet bulletins, our provider education department our unit has put together a overview or a summarized list of all of the bulletins from the past years. And so you can quickly search through those to find what bulletin you're looking for. And that's the same with the hot tips as well.
Question about also for dual eligible participants, will HealthNet pay secondary to a generic that is not preferred? So the answer is it depends. So if the primary pays nothing for the claim, then we will apply our policies to the claim. If the primary pays over half, then we will pay based on the primary paying for the claim over half and not apply our PA criteria. So we have experienced, especially with Concerta, where the primary will pay nothing for the generic. So we apply our PDL criteria to it and we deny that claim. If the pharmacy then runs for brand name Concerta, the primary will deny it. Well, at that point, we will pay the full claim for the brand name Concerta product. That's one example, and that's as of today. As we've discussed throughout this, our policies and criteria do change over time, so please keep up to date. And that's automatically handled through our pharmacy system.
And I think that we're at our 4-minute mark. If you do have additional questions that we have not addressed today, you can go ahead and shoot them to the pharmacy admin email that we have listed on the screen and found in the presentation, and we'll do our very best to address those as we see them.
Okay, so just our next webinars, we'll have one on August 17th. It'll be our annual legislative update. And then on September 21st, we'll have our annual compliance with an extended question and answer session webinar. Someone did ask the question, do we record these? Yes, we do. We record them. You can find them on the board's website. It could take up to 15 days before they get posted there, though. Previous ones from this year, I did a pharmacy technician update in April, and then in May, I did a drug distributor third-party logistic provider update. So both of those are on there, plus all our previous ones are on the board's website. On the board's website, if you go on the left side where it says resources and publications, click that, and then there's a link to the webinars. For those wanting continuing education, you must complete the post survey to earn CE. So do not close your browser when I'm saying the webinar has ended. A little screen will pop up. It's telling you that I will have ended the webinar. You click close on that. And again, do not close your browser. And the survey will pop up with the 5 questions for you to answer. Answer them online and click submit. If you do not get the questions, and this happens sometimes on tablets and smartphones, you can email us at compliance@pr.mo.gov and we will email you those questions, but you must have the answers back to us within 24 hours in order to receive credit. Again, we will mail you email certificates. We no longer mail them, we will email them, and it can take up to 30 days before that occurs. And just a reminder, save your certificates. The board does not submit to the CPE monitor. So I want to thank Olivia and Josh for coming today to give us this very informational update on the Mo HealthNet program. So thank you both for coming. And I am now going to close the webinar.